Next guest is a Hoosier who spent his career in healthcare reform, research, and innovation. This is a cabinet secretary who actually worked in the department that he now is running under President George W. Bush. He was at the Department of Health and Human Services as general counsel and deputy secretary. After that, he was in the private secretary at Eli Lilly, including being Mr. President of Lilly USA, the company's largest affiliate. It's our honor to welcome to the Axios stage, Secretary Azar. Mr. Secretary.
Thank you, Mike.
Thank you very much. Thank you for joining us here, Mr. Secretary. Happy anniversary. January will be 1 year in the job.
Yes, absolutely. 1 year.
How are we going to celebrate?
How am I going to celebrate? I'd like to celebrate by talking about all the work that the team has done. I mean, we've been going at just a breakneck speed. You know, today's actually the 7-month anniversary of when we put the prescription drug blueprint out. And it has been just, everyone said when we put that out, people said it's going to take a long time to get things done. We have ticked off now almost every single item that we had in our administrative power to do there. Charging through that. A couple more things coming. Yep.
All right, start with news this morning. New overdose data from the National Center for Health Statistics. Another dimension of a crisis that you've been talking a lot about, the opioid crisis. The number of overdoses from cocaine nearly doubled from 2014 to 2016. Why does that stat matter to us?
Well, any type of substance use overdose matters a great deal. I think it matters also because we have to get to the bottom of what's going on there. Fentanyl overdose deaths, of course, keep going up. Cocaine overdose deaths going up. The question we have to really get to the bottom of is much of that the lacing of cocaine with fentanyl. We certainly have seen some of that. We just have to, CDC's got to break apart how much of that trend is attributable to fentanyl lacing there. The good news is we've seen also with that data, we have seen the continuation of the plateauing of overdose deaths. Still up year on year, but this is really a remarkable plateauing here of deaths, which is a major advance.
But this is a crisis that is not ending.
No, it's not going to end tomorrow. It took us many, many years to get into it. It's going to take many years to get out of it. We have a whole country that basically across all generations, all socioeconomic levels, all geographies are impacted by this. You don't get out of it overnight, but every single statistic and trend line is going in the right direction, not the wrong direction, and that's good.
So just after Thanksgiving, you appeared with the First Lady talking about opioid addiction, and you said it's not a moral failing, but a medical issue.
Yep. I didn't get enough credit for that as a Republican health secretary saying that. No, we believe that. You have to break out of the mindset you may have of what it means to be an opioid or heroin addict. That may be a vision you have from the 1970s. It's out of date. I mean, these are people, most people who become opioid addicts got into this by getting a legal opioid prescription for ankle surgery or wisdom teeth, and they became, through no fault of their own, addicted. And they get trapped in this cycle. It's a physical dependence as well as an addiction, and there are gold standards for getting out of that, and that's medication-assisted treatment.
So you talked about this being the 7 months of your rollout of the drug pricing plan. This was a big promise of President Trump. Sam Baker points out to me that you've tried a lot of things. You've hit pharma, you've hit middlemen, you've tried using competition, you've tried using Medicare's purchasing power. What's going to stick?
All of it's going to stick because what we're doing, we're not playing for cheap gimmicks or headlines here. What we're doing is attacking this very broken system of drug pricing, root and branch. And what it means is we're using our expertise to take apart each piece. Each piece, take it apart, rewire it to get the incentives for lower list prices, better negotiation, lower out-of-pocket for seniors, and foreign free riding. Those are the goals the President set, and we're taking apart each one. It's not one simple, fancy, sexy thing that you can just say we've done it. This is enduring change. It takes time, but it will bring real enduring change.
Now, you're going to continue to announce some additions to that next year. Give us a little sneak peek of, over the next couple months, what we'll be hearing from you on this topic.
So we have really nailed down a lot of the proposals around drug pricing, but there are a couple more still in the works. And as I say, people ask what's next. I say, read the blueprint. No one believed me when I said that back in May. And now I think they're regretting that they didn't actually pay attention and just read the blueprint. I laid a strategy out, for the president laid it out, and we've been marching through that. And that's what's coming next. Read the blueprint. The big shift is going to be, we're going to focus a lot on what Chairman Alexander just talked about, is the move towards value transformation in healthcare. that other of the 4 key priorities we've got, you're going to see a lot of action in the next couple of months there.
And translate that. How does that hit the road?
So, value-based transformation, Mike Levitt, my old boss at HHS, really coined the phrase. Unfortunately, you can put a lot of different baggage into that. Here's an example of what value means. So I've got a relative who was just in a rehab hospital, and the nurses were complaining to me about Medicare's staffing ratios. And I said, what's a staffing ratio? Well, the number of nurses on the floor that have to be there. I'm like, we regulate that? I came back, I asked the administrator of CMS, we regulate that? Yes, we do. Instead, what we ought to be saying is, if my relative walks out of the rehab hospital, you get paid this much. If my relative's in a wheelchair, you get paid this much. You've done your job, you haven't done your job. And we aren't going to micromanage how you do that. Or a primary care practice, like the one that Chairman Alexander mentioned. Here's X amount of money to work with a patient, to coach them, navigate for them, advise them over a multi-year time frame. You figure out what works. Keep them out of the hospital. Just figure out how to keep them out of the hospital. Make them healthy, keep them out of the hospital. And here's an amount of money, and if you can do it for less, great. If it costs you more, you're at risk. That's value. That changes the pricing dynamic. It changes the value dynamic. It's the rewire of the whole system.
What's one more idea that you have up your sleeve for the early months of 2019?
Really, it is. The biggest things that we're going to be launching coming soon are going to be these demonstrations that Adam Bowler, our head of the Center for Medicare and Medicaid Innovation, has been working on to really launch several ships out into the water here, testing new models of how we pay in Medicare for services that moves from paying for procedures and sickness to paying for outcomes and health, and then getting out of the way. The more risk as a provider you're willing to assume, the less we're going to be micromanaging how you achieve that.
Saturday is the open enrollment deadline for the Affordable Care Act. Enrollment numbers are down. Why?
So we don't know why they are where they are right now. I would caution one possible hypothesis, and why it's important to wait until the open enrollment period completely ends, is that we actually have done a lot that has stabilized the marketplace this year. Premiums are down on the benchmark premium. We have over 25 new plan offerings, new insurers in the marketplace. You've got premiums in many states down double digits, often 20%, where they've worked with us on reinsurance mechanisms. If you simply are not making a choice and auto re-enrolling in the plan you were in, and stability, of course, helps that, you don't actually show up in the numbers of auto re-enrollment until the last minute in the system. So it's going to be very important we close the books on open enrollment and see where that stands.
So very shortly, I'm going to go to my phone of friends, Caitlin Owens and Sam Baker, right here. But before I come to them, the most recent drug price announcement you made piggybacked off a European price control plan that definitely isn't typical conservative Republican orthodoxy. How do you square that?
Yeah, my ideas have been called by the industry un-American and socialist. I never thought I'd be called that. No, we are running a part of our healthcare system. Again, this is maybe I'm at fault for we have a very nuanced approach to it. Figure out each problem in the system and fix that part of the system. This one part of our program, Medicare fee-for-service, Part B, we are a single-payer system there, and we set prices. I sit at my conference table, and we set the price of goods and services in traditional Medicare. We just set this one price of drugs really poorly. We take the list price that pharma gives us, and we pay 6% on top of that. That's under statute. So we're a price fixer. We're just a bad one. And so what we're saying is, look to what these very same companies give voluntarily as their deals to comparable economic powers. They strike these deals. They can walk away. They cannot launch their products in Germany or sell them there, but they set these deals and give us a piece of that. We'll still pay a premium over the average of the developed countries, but give us a piece of that. Well, first, it creates an incentive for them to renegotiate those deals and get the prices up in other countries so that they start bearing their fair share of R&D investment instead of free riding off of America. So it creates a trade pressure in the system, and it brings value to the American consumer.
You seem to be very skilled at a classic Washington skill, and that is managing up. You seem to do very well with President Trump. What is the key to working with and for President Trump?
Well, President Trump, he cares very deeply about healthcare. We talk about it all the time, this issue of drug pricing. He is fervently committed. I've talked repeatedly about how committed he is on getting drug prices down and solving this problem for the American people. He's a solution-oriented guy. He's like me as a business leader. He wants an outcome.
Well,
he's a pragmatist.
And you told me the smart brevity on how to work with him is listen to him.
Listen to him. He says, I want drug prices down, so get drug prices down. It's not an ideological approach. I want a pragmatic solution. Get drug prices down, and I'm going to measure you if that happens.
Caitlin Owens. Or Sam Baker. Sam,
yeah.
Hi.
Hi there. Thank you so much for doing this, and great to see you. I wanted to real quickly go back to the transformation to value-based care that you mentioned, because I remember that was a very high priority for you when you came in. There was a story that sort of blew my mind earlier this week that the NHS in Britain has finally banned fax machines. And setting aside the other myriad differences between us and the NHS, faxes still account for something like 75% of medical communication in the US. If we can't even convince doctors to stop sending faxes, which the rest of us stopped doing in the 90s, how do you get their buy-in on a different way of getting paid?
Yeah. So we want to work with physicians and providers on different ways of getting paid. I think it goes back to what I said there when I was given that example. If you're willing to take risk on how you get paid, we're going to get out of micromanaging you. If you're willing to let us pay you for the what, the outcome, we should stop telling you the how of how to achieve that. You would be dumbfounded by the level at which we micromanage healthcare in the United States in exchange for paying for procedures. It's sort of a necessary thing. We pay, if you do this, you get this money. It's an activity-based thing. So then you have to start regulating every aspect of how people do that, because all you're doing is paying for activity. If we get an outcome, the outcome's what we desire. It's like the president's interaction with me. Get an outcome, Azar. Okay? Well, physician group, hospital group, get an outcome, and we'll pay you this amount of money, clean, easy measure, and we're going to stop telling you every aspect of how to do your job. You be innovative. You figure out alternative ways to get there than we can think of. Just get the outcome.
Sam, you have 10 seconds if you want to cross a T. And another question. Mr. Secretary, we always finish with one fun thing. You are a secret binge watcher.
I am indeed. I have really horrible taste in TV, and I like TV a lot. It's relaxation. Right now, Below Deck Tahiti, best season ever. Below Deck. I shouldn't say this because you know what's going to happen now is every healthcare trade association is going to start running ads on Bravo during Below Deck. Don't worry, I skip through them. I don't watch the ads. But yeah, best season yet. So.
Mr. Secretary, Merry Christmas. Thank you for joining Axios.
Good to see you, Mike.
Thank you very much.
Thank you.